Good afternoon to everyone present here. I cordially welcome you all to TechBharat 2021, Empowering EduTech and HealthTech. TechBharat is an initiative of Laghu Udyog Bharati, Karnataka, and IMS Foundation. TechBharat is envisioned as a platform to support startups and SMEs and be a guiding light to them in navigating their entrepreneurial journey. We are lucky to have found support from the Government of India at every stage, and we thank the ministers, officials, and representatives of Department of Education, Department of Health and Family Welfare, Department of Science and Technology, CSIR, and AICTE in encouraging us and supporting our vision. We welcome you to this session on NextGen Healthcare, Digital Transformation. Making healthcare innovative in its affordability and accessibility is the biggest challenge world continues to face. The challenge is coupled with challenge in access to information and technology, improvement in healthcare policies, and reorganizing healthcare delivery systems to address basic aspects like cleanliness and hygiene in achieving universal health coverage. Further, through social entrepreneurship, access and traction to healthcare insurance, financing of healthcare services, building healthcare repositories, and adoption of innovative business models to tackle healthcare needs is essential. For this session, we have with us Dr. K. Chandrasekhar, who will be the moderator also. He started Forest Health in 2010 with a mission to play a role in eradicating preventable blindness using technology. Today, with over 5 products across 36 countries and 2,400 plus installations, they have touched more than 5 million lives. Prior to starting Forest Health, he spent 20 plus years in semiconductor industry, working in technology, strategy, sales, and business development. We are honored to have you here, sir, and we welcome you to the session. We also have Mr. Chandramouli, CTO of Shankara Netralaya, a not-for-profit veterinary institute for ophthalmic care headquartered in Chennai. He is driving technology transformation program with a mission to deliver sustainable and affordable technology for the masses. We thank you for accepting our invitation, sir, and we welcome you.
Thank you.
We also have Mr. Ravi Ramaswamy, CEO of RV Consultants. He is an industry veteran with over 35 years of experience and was previously the Senior Director and Head Health Systems at Philips Innovation Center, Bangalore. We welcome you, sir, to this session.
Thank you.
We have Dr. H.N. Nagraj, CEO at Lordshire with us today, an acclaimed medical doctor who has pioneered research in bone cements and Oxford knee implants. We welcome you to this session, sir.
Thank you.
I now request Dr. K. Chandrasekhar to take over the session and moderate it. Over to you, sir.
Thank you very much. Thank you very much. So, hello everyone, and we have a great panel and a great topic: next generation healthcare on a digital transformation side. We have Dr. Nagraj, who is a doctor himself, to give a perspective from a physician clinician perspective. We have Mr. Chandramouli, who is the CTO of Shankar Netralaya, a leading eye hospital globally known. Mr. Ravi Ramaswamy, who has been a leader in healthcare technically for Philips and GE for a long time. And I come from manufacturing medical devices out of it. So over the next 30 odd minutes, we'll try to have a panel discussion. And may I request Dr. Nagraj to start off by giving a brief about what Lordshire is doing, and then followed by Mr. Chandramouli and Mr. Ravi Ramaswamy, and then we can go deep down into our panel discussion.
Good afternoon. Thank you for having me on this panel. Lordshire is a software company. Of course, it is triggered by my interest in healthcare. And Lordshire is a technology company where we have people who are developing mobile and web applications. We had a vision to bring healthcare in a decentralized way so that we could help in many ways between the client or the patient and the hospital. Because as an entrepreneur, as a doctor, we were facing a lot of challenges in controlling the cost of healthcare. One of the biggest issues we were having was manpower. Getting the right manpower at the right time, at the right price is even today a big challenge for us. And having the optimal staffing is the major challenge across the world. So we thought the only way to achieve this is to have a platform which is decentralized, and also we try to do a distributed format, but there is some resistance from the industry. But when I say decentralized manner, if we can give access to the patient, all the information he should get directly by going on to the mobile application or a web application and trying to access services and checking the real time uh, facilities available, that would make a lot of difference in present situation. I'll just give you a very quick example. When somebody calls for an ambulance, the patient doesn't even know where the facilities are available for his problem in the nearest possible location when the patient is taken by the ambulance. I've seen, and also unfortunately when we see our data published by the government of India, more than 93% of the people who with trauma taken or even with the cardiac illness, when they're taken by ambulance, by the time when they reach the hospital, I believe we are losing them on the way. It's purely because there is no system even for the patient to realize, can I go to the nearest hospital where this facility is? Or can I, if I reach there, the nearest hospital, can I get a doctor who can look after me? This was our basic question. So that's how we started. And with technology, we are happy that we have now completed that application, both in iOS and Android. I have a brother who's a software engineer, and I come from a research background. So we both combined our ideas and we have developed this. Of course, this would have great implication in terms of patient trying to access the information directly wherever he wants to go to make an informed decision, which should be decided by the data which is we proposed actually to put this data on a blockchain basis, but there is a lot of resistance when I speak to my colleagues and other people. Because the only way we thought if we want to bring in this kind of change, let us do it gradually. Now we'll have a decentralized ledger system. That means when the patient wants to locate or any doctor, anybody who is available, it should be available on the app, not by calling a particular centralized number. And no way that a patient can scroll through 50 pages to find out who is the right doctor for that. So it's better that a patient and a doctor interaction happens through an application directly, and they choose the right people. I mean, for the patient to make a decision to choose the right person comes from many ways. Nowadays, most people in an emergency, they don't even have time to call the neighbor and ask somebody for suggestion. This was our idea. This is how we started. So we are actually trying to address this, and also we are trying to address some of the serious problems through innovation, especially in India through technology. What we're trying to do is there are almost 400,000 people sustained spine fracture due to two reasons. Because this happens in the elderly over the age of 50 because of bad infrastructure, bad roads, potholes, many reasons. Even just a simple fall at home after the age of 50 and 60, these practices are very common. But people, even till today, even doctors don't know that this can be treated and make this person mobile within 24 hours. With technology, we can do that. Otherwise, normally it would take 6 months. So this is what we are trying to promote through launch.
Thank you so much, sir. Chandramouli, sir, your perspective and
Sure. See, I think that was a good summary of how things are looking at it from somebody who wants to change the world in his own way. From as a practitioner working in a hospital where we deal around 2 to 3,000 patients on a peak, we the key challenges that we really face almost every day is patient service quality, quality of whatever we want to do from engagement to critical care, also cost and efficiency. I think all these things are at opposite ends. I think that's where we really see a lot of transformation happening, and particularly with our passion for driving a lot of automation, which has been in the foray of, we were one of the first in the country to get into an electronic medical record, even as early as around 20 years ago. I think we are fairly mature from a technology implementation standpoint. But it is still a challenge almost on a daily basis because of multifarious reasons. One is advancements in technology happening at a breakneck speed, particularly post-COVID. And second is the patient expectations has seen a quantum jump in terms of whatever we are trying to see and address. And costs are at opposite ends of servicing to all these things. We are trying to make a balance between all these three things. So what we have done from a technology standpoint is, our biggest mission, even before the COVID, has been to make information actionable. And we have brought themes which really hover around this core concept of making information actionable. One of the things that as we are a leading hospital, I think the center focus is certainly around the patient engagement related technologies. It could be the likes of bot, the likes of patient self-service. Now we really gone big time into the telemedicine itself. Post-COVID, we have seen around more than 10,000 plus patients had taken through the telemedicine route at this point of time. I think these are some disruptions which had been fast-tracked post-COVID itself. From a research perspective, I think Chandrasekhar, you are already aware that we had been in the forefront of AI adoption, and perhaps the world's first haptic retinopathy algorithm was jointly developed along with Shankar Nethralaya by Google with our partnership with Google. I think this has gone mainstream and is helping patients to really get the benefit of the pure play medical imaging and AI going together in terms of a major disruption that's happening from that perspective. And there are many other engagements like that in pretty advanced stages of getting into an algorithmic route. And looking at the process efficiency, I think no-brainers. I think the likes of analytics and all kind of algorithms that drive a lot of decisions, whether in terms of just-in-time or supply chain and things like that. I think these have been on a continuous war footing, which has been absorbed over a period of time. And we have been really going much more deep dive post-COVID and the disruption that has happened due to the pandemic. I think every little area where we can really squeeze a little more amount of efficiency is being done through a lot more automation. I think that's also coming in many ways in terms of our process improvements. As an organization, we are obsessed for service quality and all process quality, things like that. I think the automation had been we had been on an overdose of it. And since you've accumulated data right from day one, the 43 years of our existence, we use extensively our clinical management records for our knowledge update also. A lot of papers have also been presented using leveraging our data, actually. It helps our researchers. It also helps our where we are trying to understand data in a much more better shape using the big data type of stuff, and then trying to look into what to do next. I think these are things that has happened over a period of time, and as from an IT perspective, we have been modernizing from our data center, moving into cloud, moving into on-demand. In fact, post the last 2 years, I think we have seen a quantum reduction in our IT cost, particularly with use of cloud, and also increasing the availability in a big way, actually. So on the one hand, we have improved our service availability a lot more into digitization and things like that. From another perspective, we have reduced our cost of IT also by at least around 25 to 30%. I think these are things that we have seen from a pure play IT infrastructure perspective. All in all, I think also the data part of it, the code has certainly been a kind of a disruptor, but it has also seen a lot of benefits coming around because of our focus on automation and digitization.
Fantastic, sir. From a hospital, work is really over. Ravi, you've been the leading multinational companies for the last 20, 30 years, Philips and GE. So, your perspective.
Yeah, I think thank you so much for giving me this opportunity to share my 2 cents, the KC and the entire team here. I would possibly want to step back and take a slightly macroeconomic view of what this decentralization is all about. 1978, there was a meeting in Alma-Ata wherein we had about 220 countries signing up for Health for All by 2000. 2000 has come and gone. Even in 2020, we are nowhere near it. We are far away from having basic primary care to all of our staff. And India is a proxy for the emerging market. I think the story is no different in many of the other countries. Some of the problems that I find is, and Casey, you would be knowing this more than anybody else, is that the philosophy that the Western, that the multinationals had of bringing their products in India and trying to sell it or trying to do a retrofit or a reverse engineering simply does not work. What you really need to understand is how do we play around, how do we understand what the customer needs are, and how do we design products bottom up, keeping the concept the same. The quality, the value of life, be it in the US or in Singapore or in India, is the same. That doesn't change. But the workflows are very, very different. The IT enablement is very different. The skill levels of people are very different. I'll give you an example here. I was in GE and I walked into a hospital in Bangkok. This was the Bangkok General Hospital, and I knew the neonatologist pretty well there because we were supplying to them. So I go into his office and I asked him, saying, "Doctor, how are you doing?" After all the pleasantries, we came down to brass tacks and said, "Hey, how is your unit doing?" So he told me, "Yesterday we lost 2 babies." I said, "But why?" He said, "No, there was no incubators here." Now, fortunately or unfortunately, I saw a large incubator pack lying at one corner of his office, unopened. So I asked him, saying, "Hey, why do you tell me incubator is not here? I can see it right one in your office." And that was a very, very well-known brand. Okay. So he tells me, saying, "Yeah, we got it as an aid, but then it's just too complex. We don't have the nursing staff who know how to use that product." So that immediately struck a chord in me, saying that, yes, it is no point giving and donating equipment to people. The question is, you also need to train them. You need to ensure a serviceability. You need to ensure that the equipment can actually be put to good use. And so we came back, and in GE, we came up with the Lullaby range of product, a warmer and an incubator, which was a one-button start. So basically, it had only 2 controls in it. One was the power on, and the other one was the servo, where the servo would automatically take over, measure the temperature of the baby, look at the temperature differential, and then do the adjustments what is needed. So interestingly, I went back to the doctor in about a year and a half with this product, and then he asked me, saying, he went through the entire product for at the end of the day when we were having dinner, he said, "Ravi, you have kept so many levels of factors of safety out there. Why do you need so much? There were actually 7 levels. Don't you trust your machine?" I said, "No, doctor, I trust my machine. I don't trust the nursing staff. Just in case if something goes wrong, I don't want the baby to be impacted under any circumstance. And that's the reason why we are giving multiple levels of safety out there." So basically, what boils down is the life of a child in Bangkok is the same in India, is the same in the US, it's the same anywhere else in the world. Therefore, the quality aspect that comes in can never be compromised. It has got to be a CE approved. It has to sort of stand the scrutiny of the toughest of regulations. But at the same time, you need to take away the bells and whistles and adapt it to a manner that is conducive to what the relevant clinical needs of this country are, of what the emerging markets are. So that is one part of the story. The second thing that I find is, in today, India is spending about 2.3% of its GDP on the healthcare space. Now, if you go a bit deep into it, you will find COVID exposed what was there in Bangalore. We were simply not getting beds. Even with the best of connects I had with the CEOs of the hospitals, I was not able to get a bed for my friend's father, and we lost him. So that being the case, any amount of pumping in infrastructure into this country is not going to help. And that's the case with other emerging markets as well. So the question is, what are the exponential technologies that we are going to look at, which, utilizing the capability, the current stuff that we have, how does it give you a phenomenally valued output, which is exponential, so that you are able to solve the problem what is there today? The world expects almost 1 billion hypertensive cases. We got dazzled by what we saw with COVID. Now, when I look at the hypertension at the world level, it's almost out of 8.3 billion population, you got 1 billion which have a propensity for hypertension. The problems that and same is the case with COPD, same is the case with diabetes. These are all problems which will not be able to solve by pumping in resources. So obviously, what is the technology there? What is the means to an end? Is something that we really need to look at. And digital transformation is something that has shown us, saying that it can bring in a remarkable change. If I look at the automobile industry, the digitization is at 15%. If I look at telecom, the digitization level is almost around 30%. In the healthcare, sorry state, we are at 8%. That now keep this at one point, keep this aside. The other challenge that we are having is if I have a slightest cold, the first thing that I do is to go to an Aster or go to a Fortis or go to a NH and I go for a super specialist to treat me. Why is that needed? Why can't I go to a primary care center which is empowered to sort of do that sort of a treatment and then move to the secondary care depending upon the complexity and then to a tertiary or a quaternary care as the case may be, so that as it is we have shortage of physicians, as it is we have shortage of expertise. Why are we going and blocking his time for a trivial issue which can be treated by a crocin rather than trying to sort of give him that bandwidth to take on the more serious ones? That is again because there is no element of trust, there is no element of empowerment. So if we really have to start from a decentralized perspective, I think we really need to ensure that we have a fair footfall management at a primary care center, flowing into a secondary care center and then on to a tertiary care center, so that we are able to utilize the infrastructure that we have to the fullest, given that that is actually a resource. Maybe I would possibly pause here, Casey, and then when the discussions come in, maybe share some of my other factors that I wanted to. Thank you.
Thank you, Ravi, and thanks everybody. I think we have a great starting point. So I want to come to the very first basic question, which is the topic itself. So it says next generation healthcare and digital transformation. So I just want to understand whether everybody in the panel really agree that is digital transformation the next generation healthcare at all, or is still a long way to go? Maybe we can start off with Dr. Nagaraj.
Digital transformation in what context we take, it's a very wide subject. Actually. So when we look at digital transformation, if you looking at just patient records and how to transact the records, it just requires a little bit more clarity in terms of how do we secure the digital data of a patient. That's as far as the like what they have done at Sankara. It's a great initiative that they already have a lot of digital records. How do we transact this data when the patient is moving from one town to another town, and how accurately this data can be monitored and it is used is a very important factor, because I can just give you one very important example. Just happened 2 weeks ago. Patient, because of this corona, unfortunately, when patient went to one of the major hospitals, the doctor just asked, "What is your problem?" She said, "I'm not able to walk since morning," and immediately he called the neurophysician because he don't wanted to touch the patient. I believe the doctor who came, he also stood almost 20 feet away from the patient and said, "What is your problem?" Okay, she said, "From morning, I'm not able to move my legs. I'm not able to stand up. I've lost, sensation and movement." Immediately said it's a GB, a case of a GB. So you just go to Nimans. Nimans said, "We don't have beds for this kind of condition. Now you go to Victoria Hospital." Finally, she went and landed up at Victoria Hospital. They kept her for 25 days. She coughed a lot, complete sensation, bladder, bowel, everything. Nobody examined her. This is the unfortunate thing, because when we say digital record, even here, the patient who gives the record should be held responsible. Because responsible in not in the way that we need to take legal action or anything. I'm saying whenever a data is transmitted, at least when we know which was the authentic source, then when the next doctor attends to it, he can look into it both from his perspective and the previous data. But unfortunately, every other doctor going to other hospitals, they took it as, GP and one neurophysician has certified this. But only when we went through a detailed data and examined the patient, then I came to know it was we just did an X-ray, simple X-ray would have solved the problem. We did an X-ray. She had a spondylolisthesis, which suddenly aggravated because she used the Indian toilet. She sat down, she couldn't get up. So it is a vascular compression plus the compression complicating the entire matter. So since it was already 25 days with a lot of course, we did the surgery, but I think within 4 days she recovered. This is just a quick example of what digital transformation, because of all, because of the way we are accepting digital transformation, should be looked into, because we realize the same problem what Ravi Ramaswamy said. We knew that a time will come where finding a hospital bed for patients in the right place and the right time is the most difficult thing. So we started actually not even realizing one day this would be required. 2 years ago, we started this venture to find a technology where we'll have a B2B and a B2C application where we give it free of cost to the patient so that tomorrow, whenever he wants to find anything, he shouldn't be dependent on any platform to say which doctor has got 5 star, which hospital has got 4 star. It should be a real-time data where facilities are available. If a hospital comes on the platform and say that we are following facilities, and if they real-time use the software to this app, they even know how many beds are available, how many ICU care or cardiac care beds are available, neonatal care is another big problem. We wanted to link this, and only those service providers, once they link it, they can, in real time, they can say that, okay, we have a bed for this, please come over. Otherwise, unfortunately, sorry to say that during Corona time, a lot of hospitals took advantage. They just started saying that we have no bed just to scale up the demand. And we realized, in fact, in our hospital, we were doing all the surgeries by giving informed consent to the patient that we don't, do any COVID test. If you want, we will do it, but it doesn't alter the surgery outcome in the or in spine. And if they agree, we do the surgery because we know that this is going to stay with us. We know that the mortality is less, but the fear created requires a lot of bed and facilities everywhere. And we know that ventilator is not an answer if it has already affected a patient because of other comorbid conditions in a case like corona. So these are the very areas where digital technology can certainly make a lot of difference because then any person putting in his data is responsible. We thought, why don't we incorporate, blockchain technology into this so that whoever comes in, puts in the data, it stays there. Of course, nobody is perfect. When we put in a data, as long as it is not, crime, or we say that somebody who is positive, we say negative or positive depending on the lab inference. That is fine. But not even showing the record to the patient, you have heard a lot of cases already. Some of the hospital in our own family, being all of us doctors, we went to one of the hospital. They refused to even say what is the condition of the patient after 3 days, though we are getting a phone call from the patient saying that she has no symptoms, but the hospital is refusing to release her. See, these are the areas where a digital technology will make a great change because the truth will start coming out and the truth and the technology adapted to bring down the cost by getting optimal staffing, the best, because there are a lot of anesthetists sitting somewhere having no job, but the one anesthetist is doing 10 cases a day. See, the efficiency comes down and his level of earning also comes down because he cannot really devote so much on the next day. But whereas other anesthetists are not even having any work, we wanted to create a sort of ecosystem where doctors, nurses, pediatricians, physicians, everybody are able to come on a common platform without paying any money. Only if they get the service, if they make money out of it, they pay a small fee. But the real picture here was we wanted to really make a lot of difference for pharmacy distribution. See what happens, 40% of the pharmacies have closed stores. And even in Bangalore, near to our hospital, there is a very good pharmacy. They used to keep virtually every drug possible. Even we used to say from our hospital, if it is not available in our hospital, go to this pharmacy, we will give you. But surprisingly, 1 month back he closed because of many reasons. Plus, the technology has made that centralized distribution system like Amazon is taking away a lot of livelihood from all these pharmacies. I mean, so many pharmacies closing. Imagine their family members are also affected. We thought, why don't we make a platform where we don't have to stock anything, so patients can just take the doctor's prescription, post it on our application, and when they post it, they have to take a picture so that you know that it's a perfect doctor prescribed letter for him to go to the pharmacy. So once it is a letter sent like that through the app to the pharmacy, it can immediately send it to the patient can restrict whether he wants to send it to 5 kilometer radius or 10 kilometer radius. So all the pharmacies can immediately see the prescription and code how much they are willing to deliver the same drug. And if they are delivering some other drug, the moment they prepare an invoice and send it to the patient to pay, our AI in our office, Lord Share office, reads the invoice he has sent, and we immediately alert the patient and the store that the drugs what you have prescribing or dispensing is not as per the doctor prescription. So the moment it picks up that kind of thing, then the pharmacies will become a little bit more careful. We don't suggest or say what kind of drug should be given generic or a research molecule. But the system says whatever the doctor prescribes is what pharmacies are supposed to dispense. But the advantage here is even a small pharmacy fellow now can deliver the drugs, even if he doesn't have the stock, he can procure it and deliver within the neighborhood in a matter of 2 to 3 hours. This was the plan and this is what we have started. We have completed this. This is one of the examples what we are saying how digital technology should be used to the best.
Thank you, Doctor. Chandramouli sir, Shankar Netralaya is extremely famous for doing high quality clinical care and high quality research. But do you think the next level of growth is going to happen through digital transformation, or it will continue to be the same format which was earlier?
$1 million question. It's somewhere in between, actually. What we have been discussing in various meetings and forums and things like that is the first level of contact can probably be bridged with better usage of technology. I think that's where we have seen growth. Particularly telemedicine became an overnight success because of simple lack of access, of physical access. So there was naturally a desire for people to come and consult the doctors. When we started our immediately post-COVID, actually, the first use case was to go completely online to counsel the patients who has been operated upon, but who will not be in a position to come to the hospital for all good reasons. So we saw around 7,000 of them getting benefited in less than 2.5 months' time. Completely using a it was a sheer transformation story where just around 5-6 people putting together a very hybrid platform on the cloud, were in a position to dramatically reach anywhere up to 600 to 700 patients a day, and we were in a position to really see all the patients who had been operated upon but who couldn't be counseled. Completely online, actually, through a choice of technology. So that was a very good case where we really saw some good transformation happening, really fast time to do something. And where we have also been seeing is now that still although the guidelines have been relaxed and so many other things have been moving around, I think now there is still an amount of tests that needs to be done. Particularly ophthalmology is big time on doing all this clinical imaging, which no proper diagnosis could be done. So where we thought of having a different idea about, we struck a partnership with Titan Eye Store, and thanks to that, I think the people can really walk into a Titan Eye Store, get their eyes checked, and we have extended our clinical solutions on the cloud for the optometrists to really record the findings, and our doctors can really go through the records and call the patient or do a video consultation for first level of check. Particularly for people demanding continuity of care, frequency of some kind of frequent checks. It could be for certain types of diseases, say like glaucoma or any of these things which require an ongoing checks. These are all areas which could be completely transformatory in terms of where telemedicine can really take over. In terms of transformation, I think that could be a real sheer transformation. And particularly, I think the doctor really articulated well in terms of the problem that he saw with one of the patients. What we can really see is the usage of AI and some of this medical imaging, like the diabetic retinopathy that we have done. I think that could really transform healthcare in many ways, where somebody who doesn't need to travel all the way from wherever they are into Chennai or in areas wherever we are, and get an advice for diabetic retinopathy. I think that could again, AI could be some sort of basically, where we are talking about democratizing screening. To put it very bluntly, I think that could be a transformation of all sorts. Commerce is already overdue for transformation. I think we have seen a good amount of case studies. I think we just heard from doctor in terms of how pharmacies are getting changed over a period of time. E-commerce in pharmacy is a natural way of looking at things in terms of getting your refills back and online, and you don't need to be remembered for so many other things. I think these are areas which can really where things are already happening. I don't think we need an introduction in some of those areas. Wellness, particularly, it's an area where which is catching attention. I think the transformation story, if at all, the likes of the Fitbits and the watches and things like that are all coming big time. I think whoever are concerned about their ongoing wellness, I think we are looking at a change. But specific areas like ophthalmology and all are a little difficult because these are specialties where it is still not consumerized yet. I think wherever consumerization could really happen, transformation is bound to be the case, and the technology is the only way where you can connect the masses with the doctors. Big change that is already happening, which is not being widely articulated about, is the elderly care in terms of where the cost is an issue and continuity of care is an issue. And for good reasons, we can't even keeping the people mobile and things like that. I think we are seeing a lot of disruptive ideas coming around. I think that could be a topic on its own, but I think we really see quite a lot of changes coming in those areas.
Thank you, sir. Ravi, it would be great to hear your perspective.
I said we have already seen the world embracing digital technology in the healthcare space. Let me give you a couple of examples on this. First one was one of the countries in Middle East. They came to us and they told us saying that it is mandated for them to do a TB screening to the immigrant population once in 2 years, which means they were doing about 2,000 TB screenings a day. And given that all of these images come in random, it was basically tiring out the physician, as also sort of spending an unduly amount of time in trying to do the diagnosis, because out of the stack of 2,000, about 10% of them would be non-normals, the balance 90% would be normals. So we sort of, they came to us, said, is there a way that we can sort of tackle this problem? They had about 1 million images with them. So they gave us that image set, and we were able to write an algorithm which had an accuracy of specificity and sensitivity upwards of 96-97%. And by doing so, basically what they would do is they would run the entire deck through this algorithm, and that would sort of parse it, saying what of them are normal and what of them are not normal. And in the non-normal, you would basically go to the next level of saying what the potential anomaly could actually be, or what's the cause why it is being called as a non-normal set. You don't stop there. What you then do is you take this entire set of non-normal and then you sort of classify them in the descending order of criticality. And you also put a confidence factor saying, I am pretty sure, I'm 95% sure that this is an anomaly, or I am 80% sure that this is an anomaly, or I am a 60% sure of this anomaly. So basically what you do is you rack and stack the entire set of images in the modality work list, in the packs. So when a radiologist walks into the office the morning, he gets to look at the most critical cases to start with, and then in a decreasing order of criticality. And then beyond that, it's for the normal cases, he gives a scan to it and then sort of moves on with life. By doing so, we were able to optimize the productivity of the radiologist, as also have him focus his energy on some of the key cases which really required his attention. And the customer wrote back to us, it was the Ministry of Health organization. They wrote back to us that they were able to see a productivity improvement of about 35% in terms of resolving the images. They were able to do a lot more with this. Now, in the medtech world, there is something which we call as the quadruple aim. And we hope that the digital technologies are going to sort of help us get there. The first one is, how do I make the experience good for the patient? How do I enhance the satisfaction of the caregiver? How do I drive positive outcomes? And how do I decrease the cost of care? So any of the projects that is being done in the medtech space is being evaluated on these 4 counts, and then only a call is taken whether this project is even worth considering or not. To Dr. Nagaraj's point, I think, Nagaraj sir, what you're doing is phenomenal. I'll give you a case of what we did in Dubai. If there is a sudden cardiac arrest, the chance of survival in Dubai, given the infrastructure capabilities that it has, is 5%. Compare that with what we get to see in Copenhagen and Seattle, which is at 62%. Now, Dubai is a small city. It's not a very big one. And they got excellent infrastructure. They have got the best of hospitals that you can talk about. But in spite of it, the survival rate is so low. So we said we will work out on something called as a Dubai Heart Safe City, which is basically like anyone. If suppose if I am on the road and if I have a sudden cardiac arrest and I fall down, somebody, a passerby, actually triggers an app saying, "Hey, I can see a person lying here," and that goes on to a command center. So from the command center, they send back a message saying, is there somebody who can do a CPR? So people near that body, near that guy, they pick it up and they do a CPR on me. Another message is sent to to a responder saying, go and get a AED. It is located in this place which is closest to you. And then you get a map which basically tells you how to go and reach that AED. Once that AED is come, and the AED also has capability to transmit live what its status is, because you don't want to go and realize that the AED is dead there or the battery is down or whatever. So you go and you know exactly the location where the AED is live and which is active. You go and pick that up, come and do it. Come and do a CPR, and then you apply the AED pulse. In the meantime, the command center will reach out to the ambulance, and the ambulance will know which cath lab can be activated right away. Who are the doctors there? Which is the one closest to you? And then the ambulance comes and picks up the patient. And when the patient is on the move, the data is picked up. All the ECG, the vitals are picked up and transmitted to the hospital so that he can go straight into the cath lab room without really having to go through the entire ER screening process and all of that. So by doing all this, what we are trying to do is to bring in an ecosystem play. This will involve multiple people. It involves the Dubai Ministry of Health. It involves the Dubai Ambulance Authority. It involves the map givers. It requires the caregivers. It requires the device providers. So basically what you're doing is you're creating a consortia in the environment by which you are able to address and solve such problems. And glad to say that this technology has caught on not only in Dubai, it has gone live in Tokyo, it has gone live in another about 7 or 8 more cities globally. So again, what is here is again digital. So there are enough and more examples, Casey, that I can talk about wherein we have made it, where digital is going to make a difference in terms of utilizing the resource that we have, and how do we scale it to a more than larger population and thereby create a positive impact.
Thanks, Ravi. Thank you so much. The question is, there has been a tremendous shift in the last 1 year towards digital. Practitioners who were practicing in a very conventional way have shifted to digital, and more of that have been driven because of COVID, right? Now, if we hypothetically assume by 2022, entire world is vaccinated, on 1st January 2023, will the world go back to the old way of treating, or will digital continue to stay? That is the question.
Yeah, unfortunately, even among doctors, they have a lot of confusion and less of a knowledge about virus. In fact, I'm sorry to say, a lot of GPs or most of the doctors are picking up the info on the television or internet rather than going back to the basics of the books. So because of this, the fear which is created successfully by several media, it's not going to allow a lot of doctors to get back to their clinical practice. Because this virus, if you keep testing every 6 months, it's going to come in one way or the other. Corona has been there with us. It's only COVID too. We had higher complication and death rate with SARS in 2003. So this is not going to go. So this frenzy or whatever the fear created by the media is going to stay in at least most practitioners. But again, slowly, in our hospital, we had an attrition of 70% within 2 months after the corona issue started. And out of that attrition, the nurses left for a better remuneration with COVID hospital, but the doctors left because of the fear. They said, we will sit at home, we will consult from home. But not every patient can be consulted from home. That's why if you think that it will be back to normal by 2023 January, maybe I think you need to train the doctors quite well. And at the same time, we doctors, we observe a lot of things. We use alcohol wipes in the operation theater. If you use alcohol application every day on the hand, we develop allergies because whatever the fat is there in the pores, that is actually protecting our skin. We are using alcohol solution every time because of the way we are presenting. Everybody, even when common men started using alcohol wipes, alcohol solution, So what are we teaching them? This is what I said. Definitely we have to start from the basics. But the fear to go, the government should stop publishing these things through media. It should go through only journals and doctors and several legal forums.
Chandramouli sir, what is your perspective?
Yeah, it could be, it's a $1 million question for sure. But what we really see is two things. It's, one is the COVID has really pushed the borders of what we have been doing very dramatically different actually. So the demand has been more coming from the patients as opposed to the doctors and the hospital itself. So I would definitely say there will be a jump in the digital adoption. But we need to see where it will be really be effectively being like what we just heard from doctor is where all it could be a good possibility where it can be really be of a great use. Particularly say like let me take the common thing which what people are largely using now, telemedicine itself, for example. With a lot of hope that we started things like that, but we also see that more and more of our follow-up patients using telemedicine. So the advantage is there's a hell amount of cost that they save, and more about convenience as well, and also getting away from the fear of coming to the hospital and things like that. I think fear plays a significant amount of change in most of the people's mind actually. I think to some extent we really see telemedicine being adopted as a means of reaching out to people purely as a matter of follow. We have seen nearly 50-50 now. 50% of our telemedicine that we do right now are follow-up rather than new cases actually. That's a welcome change. And going with the trend, one of the goals that we have set for ourselves is can I get rid of all the follow-up, at least around 50% of our follow-up cases that we try to do in a year. That's close to around a lakh of patients. Can I do it at least through a telemedicine route? That will free up time for the doctors because they can do it at their free time, not necessarily that it is going to be done in a prime time. And second thing is it will significantly save time and money on for the patient as well. Because one of the study of Shankara Nethralaya is people spend 6 times more on Shankara Nethralaya than what they spend on us actually. If I make say 1,000 rupee cost of a visit is 1,000 rupees, they tend to spend another 6,000 rupees for travel, accompanying, people who are going to accompany the patient, stay and other expenses, things like that. There is a hell lot of economic cost behind some of these initiatives as well. I think we could see that this could really be in for a long haul, particularly in certain areas. The second area which I definitely see is where the patients again demanding things like that will be more of the commerce actually. At least the pharmacies and some of these lab and other things already getting into the digital is certainly inevitable because I think people are getting used to a lot of convenience. I think we are seeing a lot of uptake. Practo's report, if I were to go through the March to July submissions, what they did, they had reported around 5 crore visits on their website, actually. That's a quantum jump, which has never been heard before. I think, going with these indicators and things like that, I think certain areas we can certainly see a quantum adoption of digital. But we'll have to really see the base. Can I get rid of an OPD itself? Probably not, actually. But whether I can do a better diagnosis before a person visits to OPD, probably yes. I think that's what I would definitely say.
Sure. Thank you, sir. Ravi, your point of view, how do you feel this?
I would look at it from a slightly different perspective. 1990, we had the economic reforms come in. And at that point in time, we said that if the government changes, the economic reforms will be unwinded, it will be winded back. The government changed, but the economic reforms continued. That doesn't change. You look at Aadhaar and you look at the UPI transactions, 26 billion transactions happening in a year on UPI, which about 5 years back, nobody even thought that we could reach anywhere close to that level. Ayushman Bharat is coming up in a pretty significantly impactful way. And then we have the HealthTech, which is going to come up. People are working on it. I think Sharad Sharma and the team are doing a fabulous job in terms of getting that up and running. And we should be seeing that live in 6 months. In fact, sandboxes are already available with us for doing the testing. Now, if we put all of this together, I think we are on an irreversible path as far as digital transformation is looked at, because for simply we don't have the resources, as I said earlier, to go and fund the healthcare of what is needed. And thanks to COVID, there has been a heightened realization of what it takes to be sort of vigilant about yourself and trying to take that extra bit of care to ensure that you don't fall on the wrong side of the line. So given all of this, I'm pretty sure that the transformation is going to continue. It is not only the healthcare field alone. Now look at sensors, IoTs and sensors. You've got the 5G networks coming up, which is going to substantially enhance the connectivity, at least between a short term at a short range and between multiple devices. We expect about 1 trillion devices to be on the network by 2050. Now, all this cannot exist in isolation. It's basically one vertical driving the other. So at least I have reasons to believe that the transformation that is happening is irreversible, and digital is there to stay and continue. Because once people start getting to see the benefits of what digital brings about, it is amazing. The closest analogy that I can want to talk about is the WhatsApp. If an 85-year-old mother can be on a WhatsApp at this age and learn how to use that application, I think digital is not far away for the younger generation.
Agree.
Thanks. Yeah, thanks, Ravi. So definitely we are seeing that there's going to be continuity. But then digital transformation also means a lot of data. And a lot of data also means privacy and protection, right? We recently saw certain information in the newspapers about data leaks on some private labs and others. What is your take on the threats which we will have from a digital data privacy, data protection? Indian government is also coming up with its own standards, which will become mandatory very soon. So, how do you see that? Is it also going to kind of derail the process a little bit, or we will still run with it? Maybe Ravi, you can.
Yeah, hey, thanks. I think that's a very, very pertinent question, given the fact that you talk of digitization. But then there are enough and more security mechanisms that are also being built. Now, I'll give you an example. I did this experiment in my office. I called 20 millennials and I spoke to them, each one of them individually, saying, given the choice between your health and the data security, what would you value more? 19 out of the 20 told me health. I said, they told me we do everything on the Facebook. Everything is open. Our entire personal life is open up there. So what are you talking about data security and data privacy? As long as you are able to use the data and give me something meaningful, which I can sort of infer from and take a certain action that is going to prevent me from falling sick or enhance my quality of life, they are all for it. Now, that is one part of the spectrum. But notwithstanding that, I think the technology is also on the move. Like, for example, I have been very close touch with Intel, and these guys are trying to build security on the chip itself. The security at the lowest level to ensure that the integrity of the data is maintained wherever it goes. You are not depending so much on the applications now as much as on the chips. So as much as you find the need for digital technology going up, the security and privacy is also keeping pace with it, just so as to ensure that that the security leaks don't hamper the progress. Government is also bringing in regulations like GDPR, what we get to see in Europe, which talks about privacy, which talks about authentication responsibilities, it talks about access controls and stuff like that. So I think the whole thing is being done in tandem with the industry on one side, trying to enhance the security from a device perspective, and then you have the government which brings in legislation to sort of manage this. I think we'll find a fine balance that will ensure that such compromises don't happen. You take the banking industry, for example. Day before yesterday, my card was compromised in the US. Somebody went and bought some stuff. But does that deter us from doing the next financial transaction? The answer is no. So I think, yeah, these things will happen. But when you really look at it as a percentage of the total transactions that happen, those are insignificant amount which can just be sort of ignored and moved on with life here.
Thanks. Chandramoli sir, managing a large patient data, how do you see this?
Yeah, to give you a broad dimension of what we do is around, although as a premier hospital, close to around 200 terabytes a day is what we handle almost every day. It's a nightmare to manage an IT operation as complex as this could be. But my take on security is, still I think we are, despite whatever said and done on the security side, the healthcare technology is still primitive, in my opinion. I don't think so. We are anywhere closer to what the banking industry is already doing or anything in the financial services. So there are almost around 99% of what we do is not available on the internet actually, because you have still need to come to a hospital to do many things today. So from that perspective, I would definitely say whether we like it or not, many things are physically secured rather than cyber secured actually in many ways. So I think some of it are pretty notional in terms of this security leaks and things like that from a hospital standpoint. Not that we are not completely still on an e-commerce part. E-commerce, definitely there is a threat, definitely for sure. But the other perspective too, so I think there are many things around the corner with the privacy bill and other things. So let's take it as it really comes. And I think these are good things bound to happen as we really go deeper into the digital world. As we give respect to the patient's privacy and confidentiality, things like that. So we are all guarded by all the secrecy clauses and other things that was inherently built around the concerns that they sign. But the other aspect to some of these things, which we particularly after the COVID, I think the industry itself requires a lot of data, because I think that's what Ravi had also been just talking around. The industry is also requires a lot of data. My view is there has to be a lot of open data set. It really doesn't matter whether the patient is a Chandramukhi. I don't think I need to reveal about who the person is. It's more about what the condition is about. I think that is the kind of abstraction that is required. And some of it we can really make it as an open data set that will really make the other players to come out with innovative solutions, or with vaccines and or look at the next big thing rather before it is really happening, and come out with a lot of other things. So the data is a kind of absolutely inherent oil that would require a lot more innovation that is required. While I really respect the privacy part of it, but equally an open data set would be an order of the day for us to really make our lives a lot more easier, because there is a social aspect to all these things. Because if you are going to hold and I don't want to pass on my data, then I don't think so we can ask for a vaccine in the next 2 years.
Dr. Nagaraj, your perspective, sir.
Well, I also have a question to Mr. Chandramouli here. It's not a question actually. It's something what we faced when I went for a talk on regenerative medicine to Bahrain. That hospital virtually that day was shut down because the security, the data was hacked, and they absolutely had nothing so that they could run the hospital. And there was a ransom claim for that particular breach of about almost 2 million. I think you must be aware of that already.
Right.
It's such a wonderful thing that they are managing so much of data in Sankara. But how are you trying to secure this? Is a $1 million question to yourself. But hats off to you people trying to have a physical security and this as well. But it's really a major issue which we must really take it more seriously now, because world is watching India now. So we need to be very careful.
Very true, sir.
And your data is very valuable to many people, even to work out a lot of things as far as healthcare implementation is concerned. But my take on this from digital side is only purely on health benefits as a surgeon and research. I'm working on drug delivery systems using a kind of pH-enabled drug delivery system, which will virtually, because I worked on this for antibiotics and we are very successful. I worked with a US company called Biomed from 93 till 96 on a product called Septocol. It was an antibiotic, but it is delivered at the site of surgery without any complications, or it doesn't permeate through the vessels to go to the other parts of the body to create complications. But the efficacy was much, much better. And we could use it even in patients where they were allergic to, let's say, gentamicin, but we could use this because there was only local reaction. So my knowledge on this, the data collection and how we are handling all these things purely based on clinical side of it. I'm not an expert to understand cybersecurity and what is happening there, but I'm sure with digitization happening, it will help the clinical research, it will help cybersecurity and the data sharing, especially when it comes to data sharing. I would say that if we all agree and slowly go towards adopting blockchain, it will give us a lot of ownership to the data available.
Correct.
Once we have the ownership, then we have no scare or fear of sharing it. We know from where, and that uh, data, when it is shared, it can be remunerated also. So what I'm saying, a lot of the data collected at Sankara, with a lot of the insight which has gone into that by the entire clinical team and the analytics team, can become a fantastic, document for a lot of hospitals to share, because we have a lot of data which we are building up after the regenerative medicine work. But when we want to share, there is no platform where we feel comfortable to share this, because I shared one of the very big opportunity with the company. I can even say that because I have all the documentation. A company known Bron. They were struggling to make a product because whenever there's an injury or major accident or a skin loss or after cancer surgery, they didn't know how to cover the skin loss, so they were using grafts and various other techniques which was costing a lot of money. So they were trying to develop a device called dermatotraction. So they gave me this project to develop it, and they said if it is developed, it will be patented and it will run through them with us as the inventor. So within 6 months, with the help of another German doctor, I developed the product in India, in Bangalore, and it was very, very successful. But we tested all these devices in Germany. We didn't test them in India because then we don't want to have a biased report. And we tested this in Frankfurt Hospital, trauma hospital, and we were successful in 99% of the cases to close the wound without skin grafting. So this was a great product. So when we went together and presented this to Bron, they were very happy. But after 2 months, we realized, even in spite of the NDA, everything, after 2 months, we realized they give it to the company to manufacture. Suppose we had this data shared through blockchain, I don't think they could have played the game, because the legal team, when we consulted in Germany, they said it's going to cost you more than €1 million to fight this case. So imagine, as an individual, how we're going to fight. I think this digital transformation is going to be the future and the magic, which will help even in research. Because if somebody is working so hard collecting the data in hospital like Sankara or any other hospital, they won't have any fear bringing out their research through the blockchain data, because it's not a rocket science to go into blockchain. It's only the minds will be ready to go in there and share the data. And there are enough technology people who will help us to create the blocks and the code.
I think, Casey, the biggest thing that keeps me awake at night is the fact it's not so much about the data being leaked, the informatics part of it not being leaked. It's a question of somebody hacking into a monitor and changing the parameter setting of the patient. Now, if that happens, then in which case the entire diagnosis goes wrong. And that is the biggest worry that I have. And that's where we spend our sleepless nights. And that's the reason why we try to see the product from a product perspective. How ruggedized can it be? And ensure that you really sort of what they call as hardening the OS and stuff like that, all the technologies that you do to ensure that the product is inherently safe.
I think we're running short of time. I'm going to ask one last question, and I have a few questions from the audience. So my last question, of course, we all agree that digital transformation is going to play a significant role in healthcare, and I am sure all of you will also agree that it's going to be a lot of these new generation startups who are going to create a significant impact in this. If you look at, and it may not be very relevant, but I still want to ask this question, that if you really look at the startup space, there are almost 30 odd, 40 odd unicorns in India. Of course, valuation don't decide anything, but still it's an important milestone. But we don't have any here, right? So is digital transformation adoption going to create the first unicorn healthcare company in India? How do you feel about it?
I somehow, I beg to sort of differ in this, where there are ambitions. I have sort of traveled extensively around the world, having worked with GE and Philips, been to Israel, been to the US, been to the Valley, Boston, Russia. The type of startups that you get to see there and the type of startups that you get to see in India is fundamentally different. For one, the support from the universities, the world ranking universities, is simply, I think India can do a lot more for itself in terms of that engagement. The second thing is the mindset itself. Whereas those guys want to make it into a unicorn, for us is the question of how are we going to sell it to the next, how fast can we exit this? You might be, your company is an exception in this, Casey, that you have that you're standing there for a purpose. But I see a lot of these other guys whose intention is saying, how do I exit this as short as possible? How do I make my money and go on to the next? Now, unless that mind shift changes, I think it is going to be difficult for us to see a unicorn here. Yeah, there could be one flash in a pan sort of a thing, but if in a consistent, methodical, systematic approach, I don't see that happening in India. I wish we take this on to a very different level and make things happen here.
Thank you. Thank you so much. So I have a few questions which have come from the audience, and I'll open it to the panel. Anybody can take it. So the question is, how AI and ML is set to transform healthcare in India? Chandramouli sir, maybe you can start.
Yeah, definitely. So I think largely, where we are really seeing is it could really from an ophthalmology perspective, although there are other areas where people are working on it. I'll confine myself to what we are doing here. Our goal is to see how we can democratize screening. Because if I take, say, diabetic retinopathy itself as a good case, I keep that harping on and on, is now looking at what the Indian population is about around 6 crore people to be screened. And there are hardly around 3,500 retinal specialists in the country. So there is no way that you can screen the entire population, even within the lifetime of all these 3,500 people put together. The only way where this can really happen is using some very disruptive things like what we really see in the AI being adopted. So definitely for sure, screening is an area where probably even getting integrated into the camera itself can really change the way we look at the first level of saying an yes or no, like what we heard from Ravi earlier on some of the case studies that he had on the Middle East. Actually, this could be the one such case which could be pretty global. Actually, there's nothing Indian about it, actually. The second thing we can really articulate about AI coming big time is also on predicting the kind of care that would be required post-surgery. Most of the times that we are running short of quality counselors who can really advise the patients in terms of their health conditions before and after. And that's where we have really seen a quantum jump in some of the algorithms that we have developed, where we can do around 95 to 96% level of accuracy for the level of vision that is likely to guess post-surgery 1 month or 6 months or a year down the line, considering his current conditions, and who could be a better doctor, who could be doing the surgery in those conditions. I think these are things which you're really seeing where AI really coming in to play even as quickly as the last 2-3 years we have seen the benefits already again. And there are many such areas which you can go on and on.
Ravi, anybody?
Yeah, I think I had Dr. Mr. Chandramouli talked about ophthalmology. Let me pick cardiology here. A simple thing like an ECG. We know that India has almost about 8% of the population which is prone to hypertension and cardiac events in their lifetime. So is there a way that we can do an early ECG screening? The question that comes up is saying, a general physician at an MBBS level is not competent to sort of do an ECG analysis. Fine, he's not competent, but then what we can do is we can take that ECG, push it onto a cloud where you have automated systems which does the analysis of the ECG and reports it back to the physician. And the turnaround time is less than a minute for all of this. So is there a way that we can use AI ML for this? There are about 70,000 cases or variants that comes up in an ECG. It is not physically possible for everybody to know all of it. But if we have a sort of an unconfirmed report or an advisory which is basically running at the cloud or even any data server of sorts, wherein you are able to feed the input and get you feed an XML package and you get an output saying, hey, this is a bradycardia or a tachycardia or an atrial fibrillation or what have you. At least the first level of diagnosis is done. And then along with that, a marker can also be done saying, does it require an immediate treatment? Does it require basically in a red, yellow, green sort of a thing? We did this actually in Manipal along with KMC, and we had astounding results in this. 40% of the people who walked in had a cardiac event. And 3 of them had myocardial infarction, where we had to rush them to a hospital for getting the treatment done and taking them on the cath lab in about 45 minutes. So the opportunity is immense. I can talk about a similar one in the mother and child care space also, where you are able to bring down maternal and neonatal deaths. We did 2 pilots, one in Shorapur in North Karnataka and the other one in Padang in Indonesia, where we saw over 1,000 women from the point of birth, from the conception to delivery, and we were able to ensure that the maternal and neonatal mortality was zero. So these techniques, there's no question about it. It will play a significant role in managing healthcare and driving outcomes.
To comment on this.
Sure.
We have initiated exercise which we're going to start in the next 2 weeks, because I feel that since I agree with all the panelists on AI and ML, the basic thing is we also need to look at collecting the data, using it to come out with some kind of answers for prevention. First of all, the prevention is the area where we are looking at, and we are focusing on metabolic disorders. So we are preparing extensive questionnaire which will be filled up by the patient or by the doctor with the help of the patient's report. Because we are seeing a lot of difference when people come and present. Why do they have, when they do an ultrasound, a fat deposit in certain organs and not in some organs? Why are they different? Why do they develop thyroid hypothyroidism at a later stage? Or why do they have more deposits on the pancreas? Or some people, why do they have, even if they have a history of, yeah, not being alcoholic, they start developing fatty degeneration or fatty infiltration. So all these metabolic disorders, if we collect it and use AI and ML in a perfect way, then we should be able to segregate these people and see, is the genetic consequence or sequence of this patient is playing a role, or is it his diet, or is it something which is inherited? All these we need to collect so that then we can pass on the data saying that this person is prone to cardiac or this person is prone to get diabetes or cancer this way. So this is where we have started our exercise, because I also believe that the future is going to be AI, and with that, I think we should be able to come together and address healthcare in the future in a much more
I
effective way.
think, Doctor, what you said
Yes.
was right. It leads you into the realm of personalized medicine then.
Yeah.
That's right. Yes.
There's another question. What is your take on IoT powered remote health monitoring system for emergency care for elderly patients?
Well, for elderly patients, especially when it comes to diabetes, or if they are, if they are wearing certain devices, which could, in real time, if it can transmit the data and if it can be monitored and then incorporated into a web or a mobile application, it is possible. So we try to do this with our application which is developed. What it does is it informs the hospital, 10 family members, and the concerned people. Even if a person suddenly has a heart attack, if he is not able to even open the mobile, but he can use. We had a talk with the Samsung people with the hardware side of it. We asked them whether we can alert 10 family members and the respective hospital and their doctor, depending on their condition. If he is a cardiac, so they can key in those numbers in the app. So they just press the button for 3 times. It gives the location of the patient in case he has collapsed in the bathroom. Because you spoke about elderly people, many times they live alone. If they, so for them, this application of informing their whereabouts and the emergency is very, very critical. So I feel that's where we can use this particular technology and try to make a difference in terms of their safety and the feeling of not being alone.
Doctor, just to add to what you said, there is something available which is called which is like a pendant which you hang on the neck. So in case of an emergency, you just press the pendant, and that sort of has the inherent capability to alert the caregivers, to alert the hospitals. But then what you realize is that you also need a surrounding infrastructure to take care of this, just the way that you have a
Correct.
911 system in the US. Otherwise, yeah, alerting the doctor, and after that, what? How does one close the loop is always a challenge.
I have the last question, and probably anybody can take it. How digital addresses telehealth and its widespread impact?
Probably, I think in the field of radiology and pathology, it will have maximum impact, because reading the pathological slides and also the radiological imaging, it'll be probably much more accurate and it can do a lot more. And also in the retinal, diabetic retinopathy is one of the best areas where we can think of, because that's where the numbers can be so phenomenal, I think we will have much more better healthcare using that.
Casey, if I may add to what Doctor said, when you're looking at an organ today, you're not looking at an X-ray or a CT or an MR alone. What you're looking at is an organ which is in a disease state or which is problematic. And therefore, the question that comes up is, how do I fuse all these images, be it the X-ray, ultrasound, it could be a CT, it could be an MR, it could be a PET scan, it could be a biopsy, it could be a genetic analysis. How do I integrate all of this to make a meaningful whole is something where digital will really come in a big way. There is no other way that you can do it.
Yeah, here one very important point I would like to make, especially when it comes to PET scan. The way the PET scan is read by different radiologists varies so much, and the way it is transferred or transmitted to the patient as a knowledge, what they should do. I think it's time that it becomes digital more than physical, because they don't know to understand how the SUV should be read, whether the SUV can be compared with the diabetic status of the patient, or how much of importance it gives for SUV uptake, how many false SUV uptakes can be considered and scare the patient to go for another 10 radiotherapy or chemotherapy. This is where I feel that technology is going to make a huge difference, especially when it comes to reporting.
Absolutely.
Yeah, I think, see, in fact, we have seen in retinopathy, different doctors write different connotations, but when you make it digital and drop down, you're restricting it to 5 or 7. So you actually also structure the doctors to come into the 5 or 7. So the interpretation becomes more or less the same. There can be difference. For example, one doctor can say something as mild, whereas another can say moderate, but we don't have something in between. So we can't interpret, because then English becomes important rather than, so if 6 or 7 drop downs are there, then it is easy to kind of.
And the other thing is also conformance to standards like SNOMED CT and ICD-10 and others.
Correct.
That will make a difference. It will bring in a certain standardization and rationalization of diagnosis.
Absolutely, absolutely. So I think thank you very much to all of you. It's been an enriching session. Complete variety, from a practicing clinician to a CTO of one of the largest eye hospitals to industry veteran on leading medical devices company. How digital transformation is going to make a significant impact to healthcare and, more importantly, to our country. And given that we have poor doctor-patient ratio and the per capita GDP spent on healthcare is still very negligible, I think as a community, as a country, we can achieve great heights if we adopt it and ensure it is put. And, not to forget Ravi's point that digital is not just a magic wand; it has to be completed with the last mile and care. Because just getting data and completely making it digital doesn't solve the purpose, but the output of that has to be taken and converted into actionable things, and that should be also available, for which infrastructure has to be there. So if that is there, I think we can hope the next 2 or 3 decades we can transform much better than what we were in the last 3 to 4 decades. So thank you very much, all of you, and so kind of you to give your time on this wonderful session. Thank you very much.
Thank you. Thank you very much. And I'm really looking forward to staying connected with you all.
Thank you.
Sure.
Sure. Absolutely, sir. My pleasure.
Thank you, sir.
Thank you very much. Take care.
Thanks, Vishu, for the
Thank you,
opportunity.
sir.
Thank you, sir. On behalf of TechBharat, a heartfelt gratitude for taking time out in spite of your busy schedules and coming and interacting on this session. We thank you, and I'm sure people will find immense value from what has been discussed today, and there will be key takeaways for them, for anybody who watches this. Thank you so much, sir, and good day. We wish you the
Thank you.
best.
Thank you very much. Thanks a lot, sir.